the silver methenamine stain, the Mason's trichrome stain, the Congo-red stain as a routine for each and every biopsy. And this is what helps us to identify a lot of diseases per se. For example, in membranous glomerulopathy, if the deposits are enough in number, they will induce changes which we call as mottling or spikes, which helps us to identify the pattern of injury. Now, DIF is critical to diagnose membranous GN. And what happens in membranous GN is the immune complexes are predominantly of the IgG. The antibodies are of predominantly IgG type. So IgG staining is very bright in IF. And if you look at the subclasses of IgG, there are 4 subclasses of IgG. And IgG4 is the most common component of these immune complex deposits. So you have a planted antigen, then you have autoantibodies towards it. They form together to form immune complexes, and these immune complexes are composed predominantly of the antibodies are predominantly IgG. And it is important to note here that in about 80 to 85% of cases, you also get a significant staining for C3 along with IgG. So in renal pathology, in routine, we use a routine panel of at least 7 antibodies. So that is IgA, IgG, IgM, C3, C1q, and both the light chains, the kappa and lambda. So in most of the cases, you would also get a C3 staining along with IgG. But there are certain cases where you don't get C3 staining, and we'll come to that as we talk about the various antigens there. So a note is to be made of the various staining patterns. And in one subset of cases, the so-called few secondary MGNs, you may also get staining for other immune reactants, including IgA, IgM, and even C1q in some cases. So we'll talk about these cases as we go on further in this lecture. So these are a few images of typical pattern of IgG staining in direct immunofluorescence. And all these appear green because the adjuvant, the fluorescent compound which we use is FITC, which is the fluorescent isothiocyanate, and it fluoresces bright green when you incident a blue light on it. And you can nicely see the fine granular staining along the GBMs, which is characteristic for a membranous GN. Having said that, there are certain subtypes or certain membranous GN which do not show a very bright staining here. And the staining at best can be called segmental. And corresponding to that, even the deposition of immune complexes is only segmental in these cases. So we call these cases as segmental MGN, and they have a unique antigenic profile, as we will see in the coming slides. Now, few of you may have heard that we actually stage membranous GN also. So the membranous GN, based on its ultrastructural appearance, is staged into 4 stages. And what these stages basically denote is the progression of the disease. So starting from the earliest stage 1, where the deposits are very scant, to the more prevalent ones in stage 2. In stage 3, the deposit starts getting reabsorbed. And in stage 4, apart from the resorption, you also get a lot of remodeling of the GBM. So basically what it denotes is the disease progression. And apart from this, it really does not have a very significant clinical correlate or outcome. So you can't really make much out of a clinical nature of the disease, apart from saying that the disease itself has, the glomerular deposits and themselves have become old. The reason I'm telling you here is because even when you have a stage 3 or even a stage 4 appearing glomeruli, you can have a minimal tubulointerstitial chronicity. So this staging actually pertains only to the glomerular progression of the disease and not to the progression of the disease overall, as you may like. Now, this is the typical appearance when you see in the electron. I was talking about subepithelial deposits. So these are the subepithelial deposits which you see, the black ones which are projecting out into the urinary space. And since they are because the target antigen is in the podocyte, the deposits are getting formed in the subepithelial space. So this is the typical appearance of a membranous pattern glomerular deposition, glomerular disease in a ultrastructural appearance. Now, till 2009, as far as renal pathologists is concerned, membranous glomerulopathy was the easiest diagnosis. So you just have a case, you see maybe thickened appearing GBMs, you do the IF, you see a nice IgG, and you will just sign it out. Very happy. So within 5 minutes, I'll be done with my case. And in this era, apart from the clinically observed association with few systemic diseases like SLE, the nature of immune complexes were elusive. So it's not that people didn't try and understand that whole thing, but it remained elusive at that point of time. So what was happening, what was where we knew the disease associations like hepatitis B or SLE, we would call them secondary membranous, and everything else was primary. So this was the concept at this point of time. But what happened in 2009, an interesting paper came out which identified the M-type phospholipase I2A2 receptor as a target antigen in idiopathic membrane. And this was a landmark paper in the sense it opened the gates for understanding of membranous gene. It opened the floodgates actually. So once we identified that membranous nephropathy, the most common target antigen is the M-type phospholipase A2 receptor, against which the anti-PLA2 or antibodies are circulating and getting bind to the immune complexes, forming the immune complexes. We started to understand what goes on behind formation of these immune complexes. Till this time, we did not know. And at that time, it was thought that around 80 to 90% of cases of membranous GN are associated with phospholipid A2 receptor antibodies, which now we know is not such a high number. We know many other antigens. This percentage has actually reduced. It's no more 80 or 90%. And it's around 60% of cases, 65%, which are PLA2R positive. And what it did in the clinical parlance was, now we had an evidence of an anti-PLA2R antibody, probably suggesting an autoimmune kind of a process. So we started calling these as primary MGN and rest everything as secondary MGN. Now, even here, there was a caveat. So we knew about 70-80%. You probably have another 5% some disease association, but we still didn't know anything about 15 or 20% of cases. So clearly, this was not enough. So clearly, PLA2R was not the only antigen which was involved in pathogenesis of membranous GN. So these are just a few images I would like to share about PLA2R staining. So unlike other branches where this is immunohistochemistry, by the way. So we do immunohistochemistry to stain the PLA2R antigen in biopsy tissue. And those brown staining which you are seeing is representative of the antigen antibody complexes which are formed there. Now, PLA2R or phospholipid A2 receptor is actually present in significant amounts normally in the glomerulus. So it may not form immune complexes in all the cases. So meaning that even if you stain a non-membranous GN for PLA2R, you would get some staining. The idea here is when you have to understand what is the overexpression of PLA2R. So it comes with experience, it takes time, but it's an important point for beginners to note that even if you're seeing brown staining in a case of some glomerulopathy, it is not membranous. So PLA2R is not used to diagnose membranous GN. It is always used to detect the antigen antibody complexes, and a pattern to it will only define whether the staining is significant or not. Now, from 2009 to 2014, the availability of IHC, or some people also used IF for staining of PLA2R, helped the clinicians to diagnose and monitor the disease, because there was a serological test also available for detecting PLA2R antibodies. This was a huge improvement in the sense you could actually diagnose a case and then monitor your treatment and see how well your treatment has done in terms of reducing the circulating autoantibodies. So as I said, PLA2R positive was primary MGN and rest everything was secondary, but this was not enough. In 2014, another antigen called the thrombospondin THSD7A type 1 containing 7A was discovered again. So this was the second antigen to be discovered in 2014. And at the time when it was discovered, we thought about 5% of cases were thrombospondin positive, which now we know it is not the case. So actually thrombospondin is very rare. And even in a large center like ours, where we see almost 25,000 biopsies, we don't get more than 8 to 10 positive thrombospondin cases in a year. So it is definitely a very, very uncommon antigen. Nonetheless, it told us more about the pathogenesis of membranous GN, and we started discovering more and more antigens and getting more and more insights into the disease process. So this image is from one of our cases. The pattern of staining remains the same. So we use the ISC staining and try to decipher whether that particular antigen is forming immune complexes in this particular case. Morphology remains the same. There is no difference. Now, what happened beyond this, probably in the last 5 to 6 years, there has been an explosion of knowledge in this area. And to the extent that almost 6 to 7 months, you have a new antigen being described, right? So, but that's helped a lot in understanding the whole disease process. So now we know that there are a large number of antigens which are described that includes exhaustocin 1, exhaustocin 2, NEL1, about which I'll talk in a greater detail because it's a very, very important antigen. Then there was an intriguing curiosity about children developing membranous nephropathy. So we had no answer that why are and what is happening to these children, small children, 2, 3, 4, 5 years of age, developing a disease which is actually more prevalent in a very, very older population. So there was something different in these kids. And we discovered that semaphore 3b is one of the most important target antigens in pediatric membranous GN. After that, a lot of antigens have been described, the protocadherin 7, the neural cell, the NCAM1, another many other antigens. I'll enumerate them as we go along. So what I'll do now is I'll quickly take you through few of the important antigens. I'll stop for a while at NEL1 because it has a very, very interesting and a relevant story behind it. And then we'll talk about how in the clinical parlance, all this explosion of knowledge and all this confusion about antigens, how can we make sense out of it? So exhaustocin associated MGN is a very important development in the whole pathogenesis scenario. Because if you, as a clinician, many of you would be attending this seminar, would know that there is in a lot of cases a challenge between diagnosing a membranous GN versus a membranous lupus nephritis. So membranous lupus nephritis may not have all the characteristic clinical features at presentation. And when a biopsy is done, even we are at a loss many times to tell whether this particular disease is actually an autoimmune or lupus associated disease or a conventional membranous GN. So exhaustocin 1 and 2, these are two different antigens, but they have a very, very similar immunological profile. So that's why they are often spoken of as together. And in a large number of lupus, non-proliferative lupus cases, especially membranous class 5, you get exhaustocin 1 or 2 staining. So if you have a case where you're not able to decide whether it is a membranous lupus or a membranous GN, and if it is positive for exhaustocin 1 or 2, there is a high likelihood that this whole process of membranous GN is autoimmune, and a patient is very likely to have an SLE-associated disease in this scenario. So the clinical implication of this discovery of this antigen was that the patients of lupus nephritis, of lupus membranous lupus nephritis, who have an exhaustocin 1 or 2 positivity, actually have better clinical outcomes compared to the exhaustocin 1 or 2 negative mammalian. So that's a very important finding here. And there are a lot of studies which are going on right now. So it will become imperative. So even if you have a membranous lupus nephritis, the exhaustocin staining can actually serve as a prognostic marker. So going forward, there will be a lot of studies. Probably some of these will also get incorporated into the classification of lupus nephritis. And that is exactly where we are heading going forward. And another important thing, which I think it's at this point only I should tell everyone, that of the 20 odd membranous antigens which we know now till date, exhaustocin 1 and 2 are the only ones in which we have not been able to demonstrate circulating autoantibodies. So maybe our detection systems are not that clear. So that the important implication of this point is it will be very difficult in absence of any circulating autoantibodies to judge the therapy. So it will be difficult to monitor those cases, unlike other cases. But probably, hopefully, our detection methods become more refined and we are able to detect them, because I'm sure there are autoantibodies. So it's only a matter of time that we be able to detect them in circulation also. So this is from one of our own cases. So exhaustocin, we do only exhaustocin 1. By the way, we are not doing exhaustocin at this point of time. We will soon start doing it. And on a one-to-one basis, more cases of membranous lupus nephritis show exhaustocin 2 actually than 1. So it's important to include exhaustocin 2 also in your staining repertoire if you want to do good justice to your cases. Now, I was talking about the childhood membranous nephropathy, and this is the antigen. The semaphore 3b is the antigen which is most prevalent in membranous nephropathy in children. And in the original cohort where it was described by Dr. Sanjeev Sethi and his group at Mayo Clinic, about 73% of the cases in their original cohort of children had this semaphore 3b. We do see them in our practice also, and a lot of them are actually occurring in children. So it's a very important marker to have in your laboratory. And antibodies to SEMA3 have been well detected in patients having membranous GN associated with semaphore 3b. Now, the practical implication of this is now since we are diagnosing these cases, we have realized a large number of semaphore 3b associated pediatric MGNs actually have a genetic basis. And on the other side of it, a lot of these children who are not biopsied at point of time and are being treated like sRNS actually have this semaphorin associated membranous GN. So it's a good idea to biopsy all the sRNS, which I'm sure the pediatric nephrologists are doing now. So this is from one of our own cases. Semaphore, you can see that glomerulus, which is staining, fine granular staining along the GBMs. And there is no difference in the morphology. Everything looks the same, but it's only the target antigen which is different in these cases. Another antigen is protocadherin 7. So this is an interesting development. You remember I was talking about C3 staining in membranous GN, right? So around 80 to 85 to maybe 90% of cases do have C3 staining. The moment, if you see a case where there is no C3 staining at all, and this is the antigen you need to look for. So this particular target antigen is associated with extremely low levels of complement activation. And as a matter of fact, we've seen a couple of these cases, and few of the cases in the original cohort actually had spontaneous resolution of the disease. So not having complement as a part of immune complex dysovulation is probably a favorable prognostic indicator. And these cases follow a very favorable clinical course in long term. And similarly to the exhaustion 1 and 2, we've been talking about NCAM1 has been there for some time. So this is called the neural cell adhesion molecule. And serum from patients who have NCAM1 positive membranous GN, they have circulating autoantibodies. And a few cases of membranous lupus nephritis actually have NCAM1 positive antibodies. So this is another stain which you can use to detect autoimmunity associated with membranous GN. And a lot of others have been described with time to time. So we have an HTRA1 associated, which there is no real clinical association at this point of time. And these were actually discovered when they started doing mass spec staining on the quadruple. So at one point of time, we had only 4 antigens. So whatever was negative for those 4 antigens was again subjected to mass spec and other bioinformatic platforms. And this one was HTRA1 was discovered. So as we see more and more cases, we will probably start recognizing more and more clinical associations with these target antigens. The first step is conquered. So we know the target antigens. Now we just need to collect more cases, get more experience to identify the clinical spectrum associated with these. We talked about thrombospondin earlier, and even in the original cohort and even in our experience, a good number of these thrombospondin positive cases have an underlying malignancy. So this is one important development which has happened over the years. And from a pathologist perspective, there is in some cases of thrombospondin, you get a peculiar coarse granular pattern of staining in IgG. So this is what has been described here. I've taken this from Twitter from Dr. Sethi. We do see this in our practice also once in a while. So instead of that fine granular staining of IgG along GBMs, sometimes you get this lumpy kind of a staining. So these are few of these thrombospondin positive cases for unknown reasons show this peculiar pattern of IF staining, which is important for pathologists to keep in mind. Now I'll stop and for a few slides on N1 associated membranous GN. So this probably has emerged as the star antigen after PLA2R. And now we know that after PLA2R, this is the second most common target antigen in membranous GN. And it is even more important in the Indian subcontinent because of the coming slides, I'll let you know, because of a lot of associations with one peculiar disease, the alternative drug medications and other things which are prevalent in India. Now, from a pathologist's perspective, a very striking feature of NEL1 associated membranous GN is its segmental nature. In the sense, the deposits are not present diffusely throughout the GBMs, and they are present only in segmentally. So you have one capillary which will show you some deposits, 2-3 capillaries you won't have anything at all. Then in some capillaries you have few deposits. So that makes the diagnosis even more difficult. And sometimes it's so faint that if you don't see it thoroughly, you will just miss it. And these are the cases we call segmental NGN. Segmental NGN has been recognized over last 2 or 3 decades. It's not something new. But now we know that a large number of these segmental MGNs are actually NEL1 associated membranous GN. And if you talk about the so-called primary and secondary spectrums, a term which is now losing its relevance completely, NEL1 probably is the most prevalent across both these spectrums. So you will have cases where you will be able to pinpoint an etiology, and there will be cases where you would be probably calling it a primary NEL1 associated membranous GN. And in the original cohort, which was described by Mayo Clinic, a strong emphasis was laid on NEL1 being associated with malignancies. So we've had a fair amount of experience. In fact, we probably have seen the largest number of NEL1 positive cases in the world till date. And since we are seeing it in a restricted geographic location, in our experience, the association of NEL1 with malignancy is very, very uncommon. And we see a lot of other things with NEL1 associated gene, but definitely not malignancy. So the disease association is probably more stronger with thrombospondin rather than NEL1 as far as malignancies are concerned. So it's a learning curve for all of us. Probably once we see more cases, maybe more things will emerge, but this is the situation at this point of time. So this is exactly what I was describing. So the many phases. So NEL1 associated membranous GN could be a part of a malignancy. It could have an autoimmune etiology. There are cases described with sarcoidosis, infections. Even in post-transplant, I have personally seen a couple of cases post-transplant NEL1 associated membrane GN. Some cases of hematopoietic stem cell transplantation, drugs, indigenous medicine, and you name it and you have it. So NEL1 is probably a most prevalent amongst all these spectrums. However, one striking thing which has happened in Indian subcontinent particularly is the association of NEL1 associated membranous GN with traditional or so-called indigenous medications. And this is a glaring reality which is staring at our face. We see it day in, day out. And to the extent that now, whenever you have a NEL1 associated membranous GN, you should take a very, very detailed and probing clinical history of any of such kind of medications. And in our cohort of, I think we've seen a very, very large number of NEL1 cases. A great percentage of them actually have revealed some underlying medications. I'll come to that in a moment. So this was a very fantastic, great paper by Dr. Anila Kurian from Chennai, who collaborated with researchers from Arcana Labs. And this is what they came up with. So if you see patients who were taking traditional medications, now only 88% of them were actually NEL1 positive. That's a huge number. And on the other cohort, the non-traditional medication, so-called, if you want, only 5% was NEL1 positive. So there is a very, very clear evidence of contribution of traditional medications in development of NEL1 membranous GN. So this is one part of it. And this is just to show you the patterns of staining. So you can have a diffuse staining from a very segmental staining. It's no different from other forms except probably thrombospondin in some cases. But this is more segmental in nature. So many cases of NEL1 positive GN show you a very segmental nature of staining of IgG in direct immunofluorescence. And this is how the IHC would appear. So if you see the image on the top right, so you can see that large number of capillaries are not staining. It is only a very few number of capillaries which are staining. And this is exactly what the segmental nature of what I was talking about. So segmental membranous GN is a very, very strong indicator of a NEL1 associated membranous GN. Now, as we probed harder into our own patients, we realized that many patients were taking indigenous medications. Then the clinicians also identified there was some peculiar clustering of cases within families. So when these cases were probed harder, a very interesting thing came up. So a lot of these patients were actually using face whitening creams. And although our name doesn't figure in these two publications, both these cases were diagnosed by us. And there was a family of 3 sisters who were using the same face cream, and they all 3 landed up with the same NEL1 membranous GN at different points of time, very closely, temporally very close. So that's where the eyes were opened, and we realized that it's not just the traditional medications which are responsible, but even such peculiar things like face cream. So what was in this face creams was the question. So why was this association with face cream so important? So we realized, so once the toxicological studies were done on these cases, and this is a circular which has been released by US FDA last month. And skin products containing mercury and hydroquinone have been delineated by FDA. And excuse me. So this is the picture they had come up with. So this is not my thing. This is an FDA warning. So they kept a task force which over a period of probably 2 years collected a lot of samples of face creams from across the world, and then subjected them to toxicological analysis in their US FDA approved laboratory. And this is what they got. So the maximum permissible limit of mercury in these cosmetic formulations is 1 ppm. And you just have a look at the amount of ppm of mercury which was in these cases. And a large number of these cases, you had a membranous GN, which was NEL1 positive. So to the extent of 22,000. So where you have an upper permissible limit of 1 ppm, some of these creams actually had 22-25,000 ppm of mercury. And this is the toxicology agent which had a common theme with Nel1 associated membranous GN. And we are seeing more and more of these cases in our routine clinical practice. And interestingly, a large number of these creams on the left side have originated from the Indian subcontinent. That includes India, Bangladesh, Pakistan, and Middle East. So a lot of these formulations are originating from this area. So much so about membranous Nel1 positive membranous GN. So it is the second most common. I'll come to that in a while. So after PLA2R probably, which accounts 65%, about 15% of cases of membranous GN are associated with Nel1 positive membranous GN. Now we were talking about other etiologic agents. Now, once we knew how to diagnose these cases. So by the way, most of these target antigens were discovered using a technology in which you dissect out the glomeruli using a laser capture microdissection. And then you subject that dissected glomerulus to proteomic analysis by mass spectroscopy. So you have a laser capture microdissection followed by mass spectroscopic analysis, which enabled identification of all these antigens. And since we started doing it in a lot of cases, we were actually able to discover it with specific diseases also. So this NDNF is another case where we have a syphilis, and I was fortunate to be a part of this discovery cohort in this case. So NDNF, the neuron-derived neurotrophic factor, is a specific target antigen for syphilis-associated membranous GN. And there was an enigma around membranous GN with NSAID use. So it was kind of an anecdotal with a lot of times. So you have cases of membranous GN, you take a history, the patient has been taking NSAIDs for a long time. So now we have actually described and discovered an antigen called the protein convertase subtilin, the Kexin types, its long name, but we can call it PCSK6. And this is a target antigen in NSAID associated membranous GN. So now we know, so what is happening. So we, apart from broad disease associations, we now have target antigens by which we can identify specific diseases per se. So that's a very important advancement which has been made over the years. So this paper came out in 2023. And as if this was not enough, a single paper gave 7 more antigens. So taking the tally to 20. So now we have 20 antigens which have been described. And these 7 antigens were described in a single paper, but they use a slightly different technology to detect these. So as I told you, laser capture microdissection followed by mass spectroscopy was used for all other antigens. But these 7 antigens were discovered using laser capture dissection followed by a protein G immunoprecipitation. So different technology. And these are the 7 antigens which were discovered in this particular paper, which originated from Arcana Labs in USA. And unfortunately, we do not really have a very clear-cut clinical correlate of these antigens as of date. We are learning about them. And as and when we stain them and detect them more, the clinical associations will become clearer. So our experience, this is we've been doing membranous GN target antigens for a very long time. And we were in fact first in the world to start doing these target antigens on a routine basis. And we used a panel of 5 initially. So we used PLA2R, NEL1, thrombosponding, semaphorin 3B, and exhaustion 1 for all our membranous GN cases. And we have recently added rotocadarin and FAT1 also. So over this time, we have seen approximately 2,500 cases of membranous GN. And PLA2R, of course, is the most common. So we have around 65% cases of PLA2R positive membranous GN, but a very large number of NEL1. So this is much higher than what the Western literature has reported or seen. So we get around 15% positivity rate for NEL1. 15% are actually negative for all targets. So even after doing this 5, we've started doing the other 2 very recently. But there is a big cohort which still we do not know anything about. And all the other antigens put together are approximately 5%. That includes semaphorin. They're very rare. Thrombospondin, exhaustos, and other things. And as I told, NEL1 is very versatile. So we now have the largest cohort of NEL1 positive membranous GNs in the world. And very large number of them are associated with indigenous medication use. So probably this percentage is going to remain higher in our geographic areas because of the various practices of medications which we follow. And as a clinician, it is a very important thing to take a note of this and probe the patients about what they have been using. So, and as I have said earlier, so in our cohort of 350 cases, the incidence of NEL1 associated membranous GN having an underlying malignancy is very low. So there are clear geographic differences, and as and when more geographic regions start doing and bringing out their data, we'll probably get more to know about this very, very interesting antigenic profile of membranous GN. So as I've told, so it's a good recap here. So that now we have disease-specific target antigens. The contactic one is associated with demyelinating polyneuropathy. Protocarrierin FAT1 is very commonly associated with a post-hematopoietic stem cell transplantation MGN. So as we are doing more bone marrow transplants now, we are also identifying a good number of cases of post-stem cell transplantation membranous GN. And a good number of these membranous GNs are actually protocarrierin FAT1 associated membranous GN. So we talked about NDNF as a marker for syphilis associated membranous GN. And we've recently also identified PSCK6 as the target antigen in long-term NSAID use associated cases. So we have very clear clinical correlates of these target antigens also. This is just a slide which is telling you these are the 20 we know as of now. And I'm sure this list is going to expand a lot in the years to come. But all this explosion of knowledge also has led to a lot of confusion. So the confusion lies both at the end of the pathologist, also gets transferred to the clinician, because having said everything, even today, we only have two target antigens where we have commercially available antibodies in serum so that you can monitor the disease. So PLA-TAR is the most common, and some centers also do thrombosponding antibodies, and these are the only two ones which are commercially available at this point of time. And by probably June or July, we will also have a commercial assay for NEL1. So that will solve a lot of problem, of course. But from a confusion point of view, how to approach these cases, so there is still a confusion. There was a confusion because this target antigen was discovered so quickly. There was no time to actually sit back and see what is the exact clinical picture in which we want to fit in and help the clinician. So most of these antigens were discovered by Mayo Clinic, and it was natural that they need to come up with a consensus report on this to clear the confusion. So recently, I think in November only it came out. So this was a paper which was published simultaneously in Kidney International and Mayo Clinic Proceedings. It was a multi-institutional study in which there was this is a consensus report on membranous nephropathy, and they have a novel classification. So this is a unique classification in the sense it does not classify as stages or something else. It's a more of a diagnostic guide, a classification as a diagnostic guide. And this is from that particular paper. You can see PLA2R is 55%. And from the original, even they have now gone up to 10%, which is even higher in our cohort for NEL1. And rest of the other antigens are very, very uncommon. Nonetheless, you keep them seeing sporadically once in a while. And as I was talking about exhaustocin 2, if you may recall, I told you about this is the only antigens where we have not been able to detect circulating autoantibodies. But the good news is that in a vast majority of others, we have circulating autoantibodies, and it is only a matter of time that commercial assays for monitoring of these particular antigens will become available. So right now we have PLA2R, thrombospondin, we'll soon have NEL1. And as we progress further in this field, you will have assays, serological assays, so that once your diagnosis of a particular target antigen associated membranous gene is made, there is also an avenue to follow up these patients with the serological levels, which is very, very crucial going forward if we were actually want to help these patients. So this is the classification which Mayo Clinic has proposed. So what it does is a two-step classification. In the sense, the first step is always the identification of the antigen. So you have a biopsy, you do the immunostaining, and then you identify these antigens. So depending on what antigen you have identified, the second step would involve identifying the disease association if present. So if you have a PLA2R, you really don't have a clear cut, so you call it primary if you want to call it. But when you have a NEL1, you have to go deeper and try to see whether the patient has an underlying malignancy, or is he taking some drugs, or is he using a face cream, or if that patient is having some underlying autoimmune disease. Thrombospondin, whenever it comes, you need to do a more than intense survey for underlying malignancy. There are many, as I told earlier, do not have clinical correlates at this point of time. But as we see more and more cases, we will definitely be able to see them. So we have SEMA4 3B for pediatric patients. We have exhaustocin 1 and 2 for autoimmune diseases. We have contactin 1 for the CIPD associated membranous GN. The transforming growth factor beta and NCAM1 again are autoimmune associated markers. You have NDNF for syphilis. We have FAT1 for hematopoietic stem cell transplantation. And we also have PCSK6 for NSAID. So we see we've gone quite far here. It's not that the confusion has cleared up significantly. And now we know how to proceed in a given case, at least to some extent. And as far as a pathologist is concerned, we actually see it's not possible to stain all the antigens in a biopsy. It is just not feasible. So even if there are 50 antigens or 20 antigens, it's not possible for us to stain everything at go. Biopsy is very small. We'll end up the entire core just staining. So we need to find a logical way of doing it. So the most logical way of doing it is to first stain for the antigens which are most common. So we first stain for PLA2R and NEL1. So that covers around 70 to 80% of our cases. And then if these two are negative, then we go on staining for other things. That will be guided by the disease question sometimes. So if you have a clear-cut case of a hematopoietic stem cell transplantation, the third antigen which I am going to put up is going to be THS, this thing. What do you call that? What was FAT1? So this is how we are going to, and if the patient is CIPD, I'll put up the contact-in one. So this is how we will approach instead of putting everything together at once. And this will solve a lot of problems going forward. The only thing, that repertoire has to be available at that particular institute. And having said that, so it's not only the pathology which will clinch the diagnosis. So it will always be serology, pathology, the patient demographics, the medicine supplemental use, clinical disease associations, and imaging workup of malignancy, which will actually help you to categorize a particular patient of membranous GN with respect to its target antigen. So the approach, as per my experience also, and as per the consensus classification also, would be two prongs. So either you approach it as an antigen associated membranous GN, where you first look for the antigen and then you go forward depending on what you get, and then you decide clinically and other things. The second is when you have an upfront of disease in which an association is there, it will be a directed study thereafter. So if you have a specific disease like HSCT, you just go ahead and do a FAT1, the protocaryotin FAT1. Or the patient has syphilis, we'll just do an NDNF1. So this is how you should ideally proceed in case. And these are the two approaches which will give you the best results in the shortest time, instead of going all out against in all the cases. And as you must have realized by this time, so there is a big gray zone still there. So there is a large group of around 10 to 20% cases which are negative for all known antigens. So all these 20 are negative in those cases. And among one of the first membranous GN disease associations was hepatitis B. All of us know that. But we still do not know what is the target antigen in hepatitis B association. So there's a lot of work going on that also. But this is one gray area which we need to cover. And this problem of membranous lupus versus membranous lupus nephritis versus membranous GN is still there. We do not have a single answer to this problem. And a very, very important question is the post-transplant MGN, of which the pathogenesis of which we are completely clueless about at this point of time. So these cases are negative for all known target antigens and probably have an alloimmune kind of a morphology. And the target antigen is yet elusive in these cases. So what is the way forward? So this is the last slide of my presentation today. So what is the way forward? So probably we know that. So I have seen the original cohort of that spectra, and there is a very, very large number of antigens which you find in these deposits. So these are the ones which have clinical associations and are above the threshold for importance. But there are other antigens which we will eventually discover, and the list is going to increase. And as I have told, the serological testing for more antibodies will be available soon. So that what it will help in the clinical follow-up and assess the response to treatments going forward. This is a very, very important area which we would want to develop into. And do the laboratories keep on adding markers to their menu? It's a very tricky question in the sense, as it is very difficult, both as a commercial entity or even if it is not a commercial entity, even if it's a government hospital which can add, it is a very, very difficult thing to keep on doing all these stains, right? It's very difficult. So it is probably possible up to 10, maximum 12, but the moment it goes above that, it will become impractical, even from a practical point of view, in the sense it's just a limited tissue available. So you can't actually put up all the antigens where you want. So what I suspect, what I hope in going forward and in the coming decade, 5 or 10 years, so laser capture microdissection followed by mass spectroscopy actually would become the method of choice in those cases which are PLA2R and NEL1 negative. So once you have a PLA2R and NEL1 negative membranous GN, so you fall in that bracket of around 20 to 30% of cases. and it will not be a bad choice, depending on how widely these techniques become available, to fall back on this technique to make a good diagnosis instead of wasting our time in trying out antigens after antigens on IHC. So this is what I think is we are heading to, and this is where the whole scenario of membranous nephropathy is currently in the scenario now. Thank you so much. Thank you.
Thank you, sir. It was indeed a very in-depth discussion on membranous nephropathy antigens. In fact, we've crossed the time limit, but then the talk was so good that I didn't want to interrupt. So there are a lot of questions for you in the YouTube chat box. I'd request you to go through them because we'll now go on towards the panel discussion.
Okay.
Thank you, sir.
Thank you. Thank you.
So moving on to the next segment, we'll head towards the panel discussion amongst three nephrologists. We have Dr. Suhas Bavikar from Aurangabad, Dr. P.S. Vali from Hyderabad, and Dr. Amit Langote sir from Mumbai. They're practicing nephrologists and they have a wide clinical experience regarding membranous nephropathy. So my first question is to Amit sir, Dr. Amit sir. So what is your approach in a suspected case of membranous nephropathy? Do you start steroids while you wait for the biopsy report, or you continue with supportive therapy?
So, the approach for membranous nephropathy is probably the same that I have for any other GN with nephrotic range proteinuria. I would obviously send the GN markers, make sure the GN markers are either PLA2 or positive or negative. And if they're positive, I would look at what is the clinical scenario of this patient, what is the biopsy finding. I have, after the detection of PLA2R, I have not necessarily done biopsy in every patient who has a PLA2R positive. Unless they have a nephrotic syndrome of 8 to 10 grams with albumin less than 2.5, severe edema, anasarca, or a rising creatinine. In these situations, I would definitely, after the initial treatment biopsy, maybe give them steroids, but I would still wait for biopsy findings to confirm the diagnosis and then proceed with any immunosuppression. If there is a PLA2R positive, if I would look for any other possibility of malignancy or no. If their malignancy is detected, then you would go along that lines. But if their malignancy is not detected, then you would wait and decide on clinical parameters. And the three clinical parameters I use is the severity of nephrotic syndromes, the proteinuria levels, 8 to 10 grams and above, the decline in GFR, and creatinine, if that's high or low. So I do not start steroids initially upfront. I would start with the RAS blockers, supportive treatment for edema, anti-edema measures, and blood pressure control if required, diuretics as and how required. And then based on the biopsy confirmation, would proceed with further treatment. If the PLA2Rs are positive, then obviously you decide what sort of immunosuppression you want to give. And I guess we will discuss that in the part 3 of the section in terms of what treatment protocols we use.
Sir, diagnosing the disease and the treatment are do cost a lot. So, do you routinely screen for malignancy in all cases? Because there's a wide range of tests that we need to prescribe.
So, Purva, I am a firm believer that you spend enough so that you are satisfied and confirmed that you've not missed anything. I have prevented and have burned my hands by not doing enough investigations in my formative practice years and realized that something that I could have picked up, I didn't pick up. I do not restrict my practice based on the cost, though obviously I try to ensure that I use the right tests and minimize the cost. But I would do the necessary tests to, you're giving immunosuppression to somebody whom you do not know or have a suspicion for malignancy, or so many times you will find an M band somewhere, or you will find kappa I mean, you may do just SPEP and you've not done a free light chain, and you will find that the free light chains were later on positive. So, some of these things, some lymph nodes here and there, somewhere in thyroid, somewhere in prostate. So I don't do all of these tests, but I would do a PET scan starting. And if I find something on a PET scan, I would proceed further, especially when looking for a malignancy. But I do a PET scan if I'm suspecting a malignancy. That's where I start from. And if I pick up something which is significant, I would investigate in that focused area so that I don't do all the CTs from head, neck, chest, pelvis. I start with a PET scan. Again, that will not allow me to look in the brain, the heart, and the liver because these are highly areas which have high metabolic uptake. But all other malignancies probably we can pick up on a PET scan.
Right. Sir, I do have a few more questions, but then I'll go on to the next one. Maybe we'll take up in the chat box.
Sure.
With the gamut of treatment protocols like modified Ponticelli, rituximab, and CNIs with steroids, which treatment protocol has worked for you in your clinical practice?
So, Dr. Alok has beautifully put up so many things, and I think we recently had a debate at West Zone, ISN West Zone, where these protocols were discussed, and we debated. I was in favor of rituximab, and Dr. Vilas Naik was in favor of Ponticelli regimen. So, I think in terms of efficacy, it's proven that Ponticelli is the best in terms of efficacy. Having said that, in the recent years of rituximab era, we have proven enough evidence to prove that rituximab is equally efficacious to Ponticelli, except in organ-threatening situation like when there is rapidly declining GFR, high creatinine, etc., where where we would probably favor more Ponticelli. In my personal experiences, I was using Ponticelli initially, but given this upcoming evidence with rituximab, I have recently, in the last year or so, switched over to rituximab. We know rituximab takes time to show the effects, and most of the trials that I've done are short-term trials, 6 to 12 months, rarely 24 months follow-ups. In those trials, you do not have time to pick up the side effects of malignancies that you would see with Ponticelli. We know Ponticelli has a lot of side effects, and rituximab is costly compared to Ponticelli. I have seen a lot of infections in my patients when I've used Ponticelli. So I have switched over to rituximab very honestly, unless it's a organ-threatening situation. The cost, I think, in the longer run, and you will find lots of evidence pro and against, and I know there are lots of ways to circumvent how to reduce the cost with rituximab by buying it directly outright and giving it to the patient, or your pharmacy or the companies could support. But from being a Ponticelli guy, I have in the last year moved to rituximab for sure, predominantly because I find rituximab equally efficacious and side effects are definitely lesser.
Sir, what is the dose you're using for rituximab?
So I use 2 doses of 1 gram 15 days apart, and then I would wait and top it up at 6 months if I do not find an adequate response.
Sir, in the meantime, when you give Ritux and there is proteinuria, which is probably massive proteinuria, how do you what do you do? Because that proteinuria disturbs the patient a lot.
Yes.
So
So ACE, ARBs will remain your mainstay along with symptomatic, like any other nephrotic syndrome that you would do. You would treat like any other nephrotic syndrome. ACE, ARBs, diuretics, salt water restrictions remain the mainstay. But people who have florid, life-threatening nephrotic syndrome or similar situations, then that is the case where I would probably use Ponticelli instead of rituximab, because rituximab has a latent period before which the action doesn't come up. And then sometimes when you do not have that much of time, then you would want to use Ponticelli regimen.
okay. Thank you, sir. We'll move on to our next panelist, Dr. Suhas Bavikar. Sir, how do you approach patients with membranous nephropathy whom you have immunosuppressed but continue to have proteinuria?
Yeah, am I seen?
Yes.
Yes,
No.
sir.
Yeah, now you are.
Yeah. Basically, as Amit had said, the antiproteinuric cocktail which we used to give, ACE inhibitors, ARBs, and Now almost there are 4 receptor blockers and 3 enzyme blockers at our help. ARB, MRA, then VRB, and then ERA, endothelin receptor antagonist, and then there's DPP4 inhibitors and HMG-CoA inhibitors and ACE inhibitors. All these 7 drugs are at our disposal as antiproteinuria cocktail. So immunosuppression keep on increasing the dose is not a good practice for a person. Membranous nephropathy, invariably, there is a rule of one-third patients will remit on their own. In my nephrology early days, we used to be taught like it's an immune complex disease, nephritis or nephropathy, and antigen antibody equilibrium, antigen excess, and antibody excess. That was the logic taught to us in our student days. So if any immune complex disease, antigen is depleted, the immune complex disease improves or remits. If antibody is depleted by your immunosuppression, again the disease disappears, antigen remaining wherever it is. So this antigen depletion or antibody depletion logic was was our mainstay in our student days. So with that, we used to treat with antibody. Basically, we could not fix antigens as Dr. Alok Sharma has recently taught to us. And we used to check for anti-streptolysin O, ANA, and many different tests which used to do. And then give antibiotics and wait for, say, 2-3 weeks to convert that fellow into antigen depleted state and then remission. That was our logic in our early days of my nephrology practice. So currently, if antigen is positive, detected as Plat2 receptor antibody positive or NEL1, this is quite frequent. A lot of cases nowadays are getting detected. So in those cases, if nephrotic state persists, then I keep adding 7 antiproteinuric drug cocktail, whichever suits the patient. Bosenta nowadays we have started using. And then, of course, Ponticelli regime remains the mainstay of therapy for those. And then recently we had a discussion on combining rituximab and Ponticelli in reduced dosages. Will that help or will that make a difference in a resistant nephrotic state case? So that was my take.
Sir, what is your opinion regarding the use of mycophenolate in patients with membranous nephropathy?
In membranous nephropathy, where the childbearing females or young children, where we are worried about their fertility, testes, or ovarian function later, we were afraid early in using chlorambucil or endoxan. So these 2 alkylating or cytotoxic drugs in Ponticelli were replaced by mycophenolate. And to our surprise, many cases do respond as they do respond to chlorambucil. So mycophenolate is a good replacement. And also this TAC or cyclosporine replacement with steroids was, though it was practiced in some of the cases where Ponticelli failed.
So, but do you think then that if modified Ponticelli is endoxan and steroid on alternate months, are you replacing endoxan with mycophenolate and then using it as the
Yes. See, endoxan is a drug which is really blamed, and truly that happens really because the female who is pulsed with endoxan or given endoxan more than, say, 180 milligrams, this thing will lose the fertility, and then even she'll lose premature menopause. So it's really a terrible drug for a disease in a childbearing age of children. So we should really seriously consider on mycophenolate rather than these chlorambucil or endoxan where it is, unless it is life threatening, particularly when somebody has crescentic GN, I would say mycophenolate should be given a second choice.
Right. Sir, in your experience, do you decide the treatment protocol based on newer antigens like what Alok Sharma sir said, or will you apply modified Ponticelli or rituximab for all the cases irrespective of the antigen?
I really wonder what's the point in fixing the antigen when so many of antigens are responsible for generating antibodies. Basically, is it the fixing the antigen will help, or because we cannot control these antigens, phospholipase A2 receptors, we cannot control or deplete them, or say there are so many antigens which are being labeled or detected. So the mainstay of therapy is reducing antibody titers. So what's the point in checking for so many antigens, depending on the staining and laser microdissection and then mass spectroscopy, unless we can reduce those antigen levels in the immune complex scenario? That was my question to Dr. Alok Sharma.
But then, sir, the thing is that the rule of 1/3 is probably there since a long time. But there is a probability that when you find these antigens, you might be able to have newer treatment modalities that will help reduce these antigens, which may have a aggressive.
No, we reduce antibodies, not antigens.
Right. But is it, we still have to find out from Dr. Alok Sharma if a particular antigen has a aggressive course in the nephrotic syndrome uh, uh, spectrum, or another antigen which is lesser aggressive than the other one. Is this possible? Have you
So
seen?
let's hear it from Dr. Alok Sharma.
Yeah, so
Is he on the line?
yeah, I'm around, sir. So in my opinion, the idea of doing target antigens is currently to identify the disease associations. So for example, if you have a syphilis, right? So in cases where you have syphilis as the target antigen, the disease, treating it would reduce the antibodies also. Of course, the ultimate aim would remain to reduce the antibodies. And that is the reason we need a lot of serological assays for that.
I agree, sir, but that will restrict to only those cases where infection is cause of MGN.
Yeah.
Majority
absolutely.
of these cases are autoimmune, and you don't have any control on antigen titers in those autoimmune cases.
Yeah, so autoimmunities are induced. So autoimmunity is only a downstream effect of the infection, or whatever maybe it may be a malignancy, maybe a face cream or something, whatever. So even in these cases, few of these cases where face creams are implicated in L1, once the patients have stopped using it and the half-life of the mercury has reduced, there is actually some regression of the disease. Secondly, I talked about PCDH7 associated cases. There have been cases where there have been spontaneous remission. So what eventually will happen, we would probably identify more and more disease associations with specific antigens. That is where and once we have serological markers for a good number of them, we will be actually able to monitor them in a better way.
Yeah,
So
monitoring, I agree.
Yes. So going forward, that is probably the treatment for a good number of time would remain probably the same. The treatment protocols would not drastically different, but how you follow up these patients would differ depending on what target antigen and underlying disease they have. I think probably that is where we are heading currently.
Purva, can I just
Agree.
interrupt?
Yes, sir.
So I think I agree with Dr. Alok Sharma, sir. I think I have two NEL cases which is diagnosed with his lab, and one was a young girl. Of course, as soon as it came as NEL, we asked for the face cream. The other one was a 53-year-old gentleman, and this was a very afterthought. When it came as NEL, I first screened for malignancy. I didn't bother asking about a face cream, but at one of those meets, I was just thinking, and I just asked him, and he also happened to use a face cream, and both these face creams were given by either the beauticians or the barbers. And if you see the barbers, the hair cutting saloon barbers, they sell their proprietary products prepared at home from generations, which use mercury because it inhibits the melanocytes. But in both these cases, I have not put these patients on any immunosuppression. ACE-ARBs take away I've checked the serum mercury levels. Both had significantly high levels. And both from 6 months on follow-up, they have a reducing trend for proteinuria. So I think there is some help in knowing the antigen from sometimes that could give you the diagnosis as to, or the etiological diagnosis. And maybe in these situations, like these peculiar situations, you may avoid using immunosuppressions and take away the inciting agent that's causing this whole problem.
Right. Sir, have you seen any coexistence of coexisting two antigens in one case, or it's just
Yeah, so that's a very important and good question too. I think somebody asked it in the chat also. So as far as the fidelity of these antigens, it's very high. So even in those cases where people have actually described two antigens, it's more of a diagnostic error than two antigens being present. So because when actually in these cases where you have, when the mass spectroscopy have been run on these so-called dual positive on IHC, it has only one antigen which has surfaced. So there is a very high fidelity of antigenic expression. And in my personal opinion, I don't think so there is any true dual positivity of target antigen. It is one antigen which is dominant and responsible for the disease.
okay. We'll move on to our next panelist, Dr. P.S. Vali, sir.
Yes.
Sir, in clinical practice, after starting treatment, what is your clinical experience in terms of reduction in proteinuria with various protocols available? Like, what is the time?
Obviously, in our trainee days, there was no rituximab. We used to depend only on Pondicherry regimen. But even for today also, we feel that Pondicherry regimen gives the best possible protein reduction. However, in this era, probably we are testing our waters with rituximab. It all depends on your CLAR2 antibody levels. If CLAR2 antibodies levels are very high, then rituximab is going to work much better than Pondicherry regimen. Therefore, the straightforward answer for your question is the best regimen which produces immediate results is probably Pondicherry regimen. However, when compared with the risk versus benefit ratio, rituximab offers a majority of benefits when compared to Pondicherry regimen. Therefore, my heart lies with rituximab, though the answer for your question is nothing but Pondicherry regimen.
Right. So,
And obviously,
yeah, go ahead, sir.
So basically, nowadays we need to reframe the question, because now the starting point is risk stratification, to what strata our patient is belonging to. Therefore, it's not the question of the proteinuria reduction, but how we balance between side effects and therapeutic efficacy. Therefore, in that way, even though the response with Pondicherry regimen is robust, still we need to opt for rituximab, because Pondicherry, as you know very well, it's a toxic regimen, and we are scared to use in this era. And if you look back, we are surprised how much dare we are having in our trainee days to use Pondicherry for every person.
Right. So then, sir, what I mean is it pretty much obvious that you're using you vouch for modified Pondicherry, or you still?
No, I vouch for 100% for rituximab. I try to find reasons whether to keep the patient either on conservative therapy. If at all I am choosing them for immunosuppressive therapy, I choose none other than rituximab. However, in those patients with rapidly falling GFR, or those patients who present with crescentic form of membranous nephropathy, for them there is no other option. The only treatment is Pondicherry. Therefore, nowadays, if I use treatment for at least 10 patients of for membranous nephropathy, 9 out of 10 will be on rituximab only.
Has it ever happened that despite of giving rituximab, you have also attempted to give another immunosuppression because proteinuria is not coming down, or any of?
Yeah, in those patients, I follow Starman trial. The Starman trial says that after giving rituximab, if at all you feel that patient is not having that much amount of satisfied reduction, you can add a small dose of tacrolimus.
Okay.
So for such patients, what I do is I give 1 dose of rituximab every yearly, and then I adjuvant in with a small dose of tacrolimus, especially at the dose of 0.05 mg per kg body weight.
Right, right. So, sir, my last question is, what is your approach to transplanting cases with native kidney disease of membranous nephropathy? And because Plateauer is, as sir mentioned, it is just in the 60% cases, do you think doing pre-transplant Plateauer is should be the dictum or algorithm we should follow?
Probably for all legal reasons, we should resort to testing CLAR2 antibodies before going to transplantation. But once a patient of membranous nephropathy is on dialysis, that's what the literature also says, even my observations says that Plot2 antibodies surprisingly become negative within 6 months of starting maintenance hemodialysis. However, we are bound to test for Plot2 antibody levels or any of the newer antigens suspected we are having before going for transplantation, at least to make sure that we have documented negative Plot2. Here lies the catch. We are looking only for talking about Plot2 antibodies, but the patient may be having membranous nephropathy because of any other antigens or the antigens which are potentially being discovered. Therefore, at least for legal purpose, we need to do Plot2 antibodies, but that does not hinder us from going ahead with transplantation.
So, sir, do you have a change in the induction protocol, or it is everything is the same?
No literature available in this regard as such elaborately. Probably just we need to go ahead with the same amount of induction.
Okay. Thank you, sir. So with that, we come to our very interesting discussion on membranous nephropathy. I think if we have, there will be a lot of questions.
वो है ना नेहरू पार्क साउथ दिल्ली के 3-10-11 मूर्ति के पास ना
So,
लगा तो रही हूँ
in case of any further questions, we can have them on the chat box, and then I can reach out to our panelists and Dr. Alok Sharma, sir, and we'll be happy to take any questions afterwards. Thank you all, and it has been a great discussion. So we'll end the meeting here. Thank you so much.
Thank you, everyone. Thank you so much, and good night.
Thank you.
Thank you, sir.